Hello, everyone, and welcome to today's Webinar Wednesday. My name is Devin Smith, Director of Membership and Meetings for Medicaid Health Plans of America. And we are here today with MedDecision, presenting their webinar presentation on technology modernization, one state's journey. Need sophisticated systems to manage the data for and assess and track the needs of complex populations they serve, and those systems must be able to provide encounter data and reporting to meet state Medicaid and CMS requirements. Legacy systems often take an outdated approach to member assessments and often do not interact with newer replacement systems, requiring significant time and resources of the members, their caregivers, and care managers. In this session, we'll discuss an example from large state Medicaid as they modernize their systems and streamline their assessments for their LTSS population and how MCOs can learn from what the state is doing. MedDecision will also examine best practices in transitioning systems, what to be aware of in system upgrades, the benefits of skip logic and shared questions and answers in assessment design, and how to incorporate social determinants of health in assessment design as well. And without further ado, I'll let Mr. Ted Jones take it away. I believe you might still be on mute. Hi, Ted, you there?
Devin, can you hear me?
Yes.
Perfect. Sorry about that, folks. Again, welcome to this webinar. Minor technology issue here, which being a technology company, we would have thought we could have resolved that earlier. Sorry about that. Again, my name is Ted Jones, and I'm the Vice President of Government Engagement for MedDecision. Here's a brief agenda of what we'll be hitting, the points today, including the state's challenge, system requirements, development, and funding. Little bit about myself. I've worked with Medicaid programs in various capacities for my entire career virtually. I am going to say one thing right now. If at any point in time you feel that I'm not clear on something, if you're just not understanding what I'm saying, throw a question in. We'll have plenty of time for questions at the end. I do have one of the most muddled accents that you will ever hear. I come out of Boston. I've lived in Florida. I've lived in Wisconsin, and I'm currently in Denver, Colorado. So as I'm speaking, my dialect picks up accents from all over the country, and sometimes gets a little bit muddled. I can park the car with the best of them, and then throw in a y'all too. So feel free to ask a question about anything. As I said, I've spent my entire career working in Medicaid. I've worked on numerous implementations, bringing customers from somewhat antiquated mainframe systems into modern technology. I've also led a claim shop for Medicaid fiscal agent, processing over 150 million claims a year. And for several accounts, I've been the deputy account manager as a fiscal agent. I've now transitioned to MedDecision. Who is MedDecision? Well, we have the aerial care management platform. This care management platform is used all across the country, including Hawaii and Puerto Rico. It's covering over 50 million lives, and we've got about 85 to 90 of the top health plans and providers across the country. We are a SaaS-based platform, software as a service, so we're not installing at the plans, we're not installing at the states. They're all using the same instance, which, as we'll get into in a minute, really gives them some benefits. We call ourselves liberators. You'll notice the colors in this presentation are not traditional colors, the bright fuchsia and the oranges. We're liberators and we're disruptors. We disrupt healthcare, we bring change, we foster change. We help people do things easier. And MedDecision has been doing this at care management, case management for over 30 years. This is what we do. We don't do case management and claim processing and several other things, provider enrollment. We focus on care management. So the state that we're going to talk about, I will not be mentioning them by name because this state is still in pilot. And so we're still moving through the implementation. But this implementation has been going on for a long time. It's a large state Medicaid program. And we're specifically focused on their LTSS population and the HCBS groups, their long-term waivers, waivers for serious spinal injuries, the elderly, blind, deaf, serious brain injury, categories that these are folks that are going to be in the Medicaid program for their entire life. These are folks that need a lot of service, folks that if they have a care manager coming or a personal care attendant coming to help them out of bed in the morning, and that personal care attendant doesn't show up, that person could be stuck in bed and not be able to get out because the system didn't alert another person to go take care of that member. So these folks do need a lot of care. The state had multiple systems, legacy systems, that didn't interact. And what that caused was a lot of wasted time for them. Very inefficient. They're doing some things on paper. And put yourselves in the place of the case managers that are out there trying to render care to these individuals and get them the appropriate care, causes untold frustration for them. So the state went through the Medicaid Modernization Program. They chose to upgrade their entire MMIS system. So we worked with the fiscal agent at the time and went through CMS, and we'll go into that in a minute too. We also wanted to streamline their assessments wherever possible, and we'll talk about that as well. Requirements. Let's dive into a discussion about requirements. I call that the "that's not what I wanted" section. How many times have we seen implementations where, and we've all seen this diagram from time to time, the user knows what they want, but the analyst is seeing something a little bit different. And then you get your developer who's seeing something and designing something completely different. And then it turns out what the user really wanted wasn't what they originally talked about. And then you get the final point of what it actually does. In a Medicaid modernization, in any system modernization, one of the biggest challenges that I've found over the years is part and tied to that. There are always multiple sources of truth. There's the folks that work on the system every single day, and they can tell you what it does and how it does it. And then there's all the legacy documentation, which sometimes isn't updated. But then there's what the system really does and how the system really handles data. So those three sources of truth have to be mingled. And as we're walking through that, again, you've got your customer perspective, you've got your business analyst perspective, your developers, and again, your customer and your tester finding out at the end that, well, the system doesn't do what it was really designed to do. Or is it that phrase that we all hate to hear, working as designed? One of the worst things that we can ever talk about. So the challenges that we faced working with this state was we were contracted with the fiscal agent, and the state had its IT group, and the state has its business users. Well, the business users want a certain item, and they convey that to the state staff, who then convey it to the contractor's BAs, who then conveys it to our developers. It's the telephone game. Things change along the way. And it was the nature of the business when we started this program, and this program started quite a while ago. We actually contracted this back in 2014, and it's been an evolving program. So we finally broke down all those walls. It had to get broken down to get everyone talking together, meeting together, speaking the same language. So the business users and the state IT staff were saying the same thing, and our design BAs and our developers and the fiscal agent were all hearing the same thing, and again, saying the same thing back. It really boils down to some essential truths. I won't be reading through this whole slide. I'm not a slide reader. Devin, I'm sure will make these slides available for folks. But some of the key points that I want to talk about is truth number 3. Change happens. It always happens. Business needs are going to change. And as a vendor, we need to be open to that. And the state needs to be ready for it too. State or whichever customer we're working with. Business needs can change from day to day. What you're putting on blue paper today, I call it the blue paper scenario of why do you put it on blue? Well, we've always done that. But why? It's just what we've done. And getting to the root of that and seeing, oh yeah, we don't need to put that on blue paper. We could put it on plain white paper. Or a state policy change, or a federal policy change. Change is going to happen in this industry. It continually does. Number 5, customer involvement. You've got to make sure your customers are talking. Sometimes it's amazing how we feel that we're open to hearing the customer information, we're open to getting information from them, but they may be afraid to tell it to us for whatever reason. They could feel that we're intimidating them because we're bringing our method, our business process, and they are sometimes afraid to say, but that's not exactly what we do. And at the very end, you'll never have perfect requirements. It happens. You can go through the longest requirement sessions known to man and have everyone involved and get everything documented. But then by the end of the day, bam, there's a policy change. Something changes, or a staffing change, or a new perspective. So you've always got to be open to that and accepting. Another challenge that we faced through this process is we would bring a new project management model to the table here. Two styles of project management, waterfall or agile. Which is right? They're both right, but it's different perspectives again. In the traditional waterfall process, which is what most of the MMIS, the Medicaid information systems are when you're implementing them, you go through a long requirements period and specification design, and then you get to coding. But again, you're bringing the whole system, and then it goes through integration, and then to delivery, and back and forth and back and forth. So it's really this big bang approach where some of these systems that spend years being designed then finally go live at the end of that time. And during that time period, one of the biggest challenges the state finds is they've had to lock down at some point their changes so that the vendor can actually make the system, develop the system for them. What this causes is a backlog of changes that have to happen once the system finally goes live. And the state we were working with, again, was used to that waterfall approach. We came in with our agile approach. Agile is about sprints, which is part of the coding word, where it's a 2 to 4 week cycle. And the customer's getting deliverables continuously through that cycle. But one of the challenges, again, that we found, as we're going through that, we came in and just expected that the state knew what we were talking about in this new type of project management. So again, you have to make sure there's a level playing field, that everybody understands what you're talking about, and that you're speaking from the same piece of paper. Another way to think about the agile model is its iterations. For example, in what I have on the screen now, iteration 1, 2, and 3, the customer is getting deployments over time. So the customer is getting continual pieces. And one of the challenges working with our state, since again, they didn't fully understand the agile model, in, for example, iteration 1, which would be sprint 1, we might make a change on the screen to add a new button. But the coding behind that button might not come along until Agile Sprint 2. Well, our customer was trying to test everything as we deployed it, and then we're telling them there's another sprint coming, there's another deployment coming, you got to get ready to test this too. And they're saying, but wait a minute, this piece doesn't work. So again, it goes back to knowledge transfer and making sure everyone's on the same page. They didn't fully understand that we were bringing additional pieces online for them. How do they pay for it? One of the biggest challenges for states is overall funding. In our environment today, budgets are getting tighter and tighter, and states need to make sure they can avail themselves of every opportunity they can. For overall funding, CMS for the Medicaid systems can approve 90% of the implementation cost back to the state. States normally would be getting 50% of that, but then 90%. So if they're spending $1 million on that implementation as a random number, normally they'd get $500,000 back, but they can get up to $900,000 back. So for the state outlay for the implementation, they're only spending $100,000, which is very beneficial for the state. The ongoing licenses, they can get up to 75% on, whereas previously it was 50%, and that's in a very specific CFR regulation. There are requirements around it, of course. The APD, which is the advanced planning document, needs to satisfy the requirements, which talk about sharing and leverage, reuse of technology. Reuse is one of the biggest points, and that's where the aerial system has come into play very well for states. By qualifying for reuse, it's taking what another state has purchased, which becomes part of the base model, and reusing that, redeploying that. For example, the first state that we worked with, they went through and got CMS funding to make certain changes to it, changes that we'll talk about in a few minutes. But that becomes part of our base model so that the next state that gets it gets the benefit of those changes. They don't have to pay for it again, and neither does CMS. Because CMS, just like you or me, they don't want to pay for things multiple times. And in the past, they have. Different ways that you can get to reuse are either using some of the existing stuff or incorporating code that you get from other states. There's multiple ways to do that. One is the model that we use, the SaaS model of adding to our base platform. Another way is doing a buying cooperative. For example, there's a fiscal agent that has a cooperative among several states, I believe it's 14 states, for what's called MAPR, the attestation software, where providers can qualify for enhanced funding for implementing an electronic health record system. So there's varying ways you can do it. States can also facilitate reuse by either hosting it in the cloud, using open source, or COTS software, the custom off-the-shelf software packages. Aerial qualifies as a custom off-the-shelf. It also qualifies as the general reuse category. One thing that states need to bear in mind when they're contracting this, whether it's a state, whether it's a Medicaid MCO, Medicare Advantage program, is as part of a COTS, software as a service, they don't get full ownership of the code, which is different from the traditional NMIS programs. This is more similar to use an example, Microsoft Excel. When a state uses it, they don't own the code for Excel. They own all the data, absolutely, but not the actual software. So as we mentioned, there's a couple different ways that states can qualify, either cooperative purchasing or COTS systems, commercial off-the-shelf. And there's several different alternatives: software as a service, which Aerial and MedDecision provide, open source code, or proprietary stuff. But let's talk a bit about some of the new capabilities that we developed with this state, things to make the LTSS program go better. For folks that don't know, the LTSS assessments for eligibility and for overall care are tremendously long. Some of these assessments are 4,000 questions long. And on a normal day, I consider myself somewhat functioning. I wouldn't want to sit through that, through a 4,000 question assessment. Can you imagine how a parent with a disabled child trying to answer that could feel? How frustrated they could be trying to get through that. So some of what we needed to do was implement the system. We had to get rid of some paper processes because some of what they did, if they're out in the field working somewhere where they didn't have a stable internet, the case manager that is, then they were reduced to doing this assessment on paper. So they've got a 2-inch stack of paper they're working their way through that they would then have to go back and data enter into the system. There's also the TEFT grant. TEFT grant was a funding opportunity through CMS to enhance electronic assessments. Of course, we had reusability, which we've chatted about a bit. And to do that, we had held multiple requirement sessions and then came up with solutions for the requirements. The dates in 2019 speak to the change that the customer made along the way. So let's talk about some of the things that we brought in, new ideas for them. Autosave. As a case manager, sometimes you're in an area where the internet is not stable. So you're working along and you suddenly lose your connection. Well, the case manager doesn't want to have to re-enter their work. They don't want to lose their work. Think of what happens when you're working on a document and you lose it. So we implemented autosave for them. So every time they're doing an answer, it's saving that answer. So the most that they could possibly lose would be that one question they were working on. If by some miracle they lost their connection just as they were hitting enter on that answer and it didn't get saved, everything else would be in the system. They also had the ability to cancel previously saved data if they needed to. And we added also some visual indicators for them. Online and offline syncing. Again, think about those areas of our country that don't have stable internet. I mean, we have a fantastic infrastructure in the United States, but in Colorado, where I am, for example, we have case managers that are going up into the Rocky Mountains to do assessments on members. And there is no stable internet. There might not even be stable cell phone coverage, so they can't use their phone as a hotspot. So we developed a process for that. The assessment needed to be checked in and checked out so that if I, as a case manager, have decided I'm going to work on this particular client today, I'll check that member out, take that member's record with me on my laptop so I can update it, and then check it back in and load the assessment back in. This is the way it really works. So as a case manager, you're planning your day and you're connected to the internet. It could be the day before, or it could be that day. You're connected to a stable internet, either in your office or from home or from any stable location. And you're checking out the members. You're pulling their assessments and their support plans and their case notes down to your laptop. Pulling a copy of them. You're not pulling the originals, you're pulling a copy down. And then you're unconnected, you're going out in the field, you're meeting with the clients that you need to meet and doing their assessments. And then you reconnect, whether it's the next day or later that day. And it's loading everything back up for you, so it's rethinking it. This is taking the assessments, taking all the scoring that creates the support plans for your members and all your case notes and getting it loaded in. And we also needed to make sure we had some override capabilities in there. I don't use the hit by a bus scenario, but I do use the win the Powerball scenario. What if your case manager checked out 10 members, went home and won the Powerball that night and said they're not going to work the next day? You need a supervisor that can check those members, force those members to be checked back in so someone else can work on them. All things to be taken into consideration. Skip logic, required questions. Again, go back to that assessment that I talked about that's over 4,000 questions. And imagine you're a parent of a child with a serious brain injury going through this assessment with a case manager. These assessments are so long, and there are things that you don't need. I, as a case manager, don't need to present to you. So why even show them to me, the case manager? For example, things that could be gender-based or age-based or condition-based. In that instance of working with the parent of a child, I don't need to ask that child about employment questions or can they drive a car. But those questions are in the assessment. So in standard scenarios, they would present to the caseworker. If the caseworker was working from a paper version before our system, again, they're seeing those pages and they're looking at and knowing they can skip the page, but it's still taking time. So with skip logic, we can just literally skip that. The system knows it's working on a 3-year-old child. So based on that age, it throws out all the employment questions that aren't needed. If there's a question about the ability to walk, and the first question is, can you walk 50 feet unaided? Well, if the respondent says, yes, I have no problems walking at all, then you don't need to ask them questions about a wheelchair or a walker, things like that. Different, and that's your condition-based. Required questions are really important because there are some questions that no matter what, they can't be skipped, that have to be answered. Certain things around support, certain things around the member. So we introduced functionality, 1, to let the case manager know that there were required questions, and then 2, to show how that tracked for them. So there's a visual indicator on the assessment to show the case manager, okay, this assessment that I'm doing has 52 required questions, and I've done 37 of them. So I know where I am and what I'm doing. ADA compliance and printing, well, again, we've got to make sure everything is compliant with the American with Disabilities Act. That's in the printouts, and that's in the support plans. In printing assessments, again, these assessments are huge. A 4,000 question assessment, if it's this massive assessment, and going back to the example I used with the child, with the parent answering for a child, you need to be able to have it configured so that it's just going to print all those questions that have answers. Why print the pages and pages of employment questions for a 3-year-old child? Time tracking. That's also something that was important because case managers and care manager agencies, they have to be able to track the amount of time they're spending on these assessments because they get paid for this. They charge this back to the state. So the system needed to calculate the units and thereby the cost. So what that meant is introducing the ability to start and stop a timer, the ability to enter log notes, and really have a view of it so that all this would go to a decision support, a data support area, a data warehouse, and that the managers could then pull that information on their staff to submit the claims. So what are some key takeaways here? What have we talked about today? Well, the ability to work cross-functional, not just internally, but with the vendors, with the contractors, to make sure that everybody is on the same page, make sure everybody is speaking from the same piece of paper, knowing that the contracts, the contracted requirements are valid and everybody understands them. Making sure that the customers know their CMS funding opportunities so they can capitalize on the funding that's available and get every penny back into their state coffers, and to identify any opportunities where they can make things move better. Automate what you can, get rid of paper processes that unfortunately happens too often. And the biggest thing is making sure that they're working with a contractor or a vendor that knows what they're doing. They've done this before, they're willing to partner, and they're willing to listen, and they're willing to change. With that, I'd like to pass it back to Devin and see if we have any questions.
Perfect. Thank you so much, Ted. And as mentioned, feel free to continue to submit your questions via the chat box. I will go ahead and start off with the questions that we have. Our first question is, does this go through the CMS certification process?
Yeah, that's actually an interesting point that I didn't hit on a lot. CMS in the past year has changed their certification process. In order for the states to qualify for that enhanced funding, they have to go through what's called certification. It's called the MECT, M-E-C-T, Medicaid Enhanced Certification Checklist, that they work with an independent validation and verification agency, an IV&V, that's also contracted to qualify. Originally, we'll say back in the day, what CMS did was just certify the original deployment of the whole system. Now CMS has changed it, so every time a module is brought on, that module gets certified. So if, for example, a state brings on a new module of case and care management or switches to a new vendor, either to or from MedDecision, for example, they'll have to go through that certification again to make sure they qualify for the funding to get all that enhanced funding. Great question.
Next question, for the LTSS assessments, how much do you end up having to customize for each state? Or do you see these assessment forms becoming more standardized?
Well, I really do see it becoming more standardized. In the past, they were extremely custom. Every state had their own flavor, but CMS does have some standards around this, and there's also an MLTS policy group that is trying to get standards across the whole country to bring everything into alignment to make it easier. In general, we find that the LTSS assessment that we've got can be modified and brought over so that there's minimal rework for a state. But a state still has the ability to customize it if they desire. Another thing to think about, and it ties in with one of the key buzz phrases that we have nowadays, is social determinants of health. Social determinants of health, while the term is fairly new for us as an industry, it's been out there forever. Care managers and nurses, they were always getting all these questions answered, and they had all this data, but it was previously called barriers to care. Now, in social determinants of health, it's really giving a picture of the population, and these assessments can do a lot of those questions. And again, an extension of that for reporting for the plans and for the states is that a lot of plans are looking at using the new Z codes, Z diagnosis codes, to really hone in and get solid data reporting across their population. Hopefully I answered that question properly for you. Went a little bit further than I intended, but hopefully that answers the question for the person.
Perfect. Do Medicaid health plans qualify for the funding you mentioned, or is that state agencies only?
Generally, it's state agencies only. I think the Medicaid health plans have a way to contract through the state for their implementation charges to get that funding, but it's actually the state qualifying for the funding because the state is paying the Medicaid health plan for their work. So as other implementation costs and their ongoing costs, it's really a way for the state to get what they're spending back. If the Medicaid health plan had a $1 million implementation charge to the state, the plan itself is still getting its $1 million. It's where the funding for it is coming from.
Okay. And next question, you talked about a pilot program. Is that something you typically offer to your customers?
Yes and no. This particular state involved, because of the TEF grant, they needed to do a pilot for that to qualify for CMS's funding. And they also chose, because of the massive changes that they're doing to their LTSS assessments and everything, they chose to do a longer pilot to really see how it will work and what opportunities they have to improve and change their business processes. The pilot is, if a state or a customer chooses to buy a pilot, they're welcome to.
Great. Any other questions? And Ted, if anyone today wanted to contact you, how can they get a hold of you?
Sure, I have a very complicated email address, ted.jones@meddecision.com. They could also go to the MedDecision website, where there's several different avenues to contact either myself or our sales area.
Perfect. Well, thank you so much for today. Thank you, Team MedDecision. Thank you, Ted, for your presentation. And thank you all for joining us today. And we look forward to seeing you on our next webinar Wednesday. Have a great day.
Thank you, everyone.